Hello, everyone, and welcome to another show of Fresh, Natural, and Live. I hope you had a great weekend, and we have a wonderful show for you tonight. We're going to be talking about weight loss surgery. I get a lot of patients who come in who are contemplating undergoing weight loss surgery, and I'm often having to deal with helping patients make this decision. So I'm very delighted to have a very good friend of mine come on tonight to help us understand this whole approach to helping patients lose weight. You know, obesity is a major problem in the United States, and weight loss surgery plays an important role. So we're going to learn this tonight. And not only are we going to talk about weight loss surgery, but our special guest understands plant-based nutrition as well. So we're going to get into that. I want to bring our panel in today. Today, I'm joined by our resident nutritionist, Isosa E, aka Raw Girl, and she treats clients all over the world with behavioral techniques and also nutritional counseling. Isosa, welcome to the show tonight. I hope you had a good weekend.
Thank you.
And without further ado, I'm going to invite our guest tonight. Dr. Garth Davis is a bariatric surgery specialist in Asheville, North Carolina. He's been there for 2 years. He's been in Houston. We're both Houstonians. And he's been in practice for over 24 years. He graduated from Baylor University Medical School in 1996. He is affiliated with medical facilities in Houston as well as in Asheville, North Carolina. He starred in a TLC show, Big Medicine. He is certified in the American Board with the American Board of Surgery and is a fellow of the American College of Surgeons and fellow of the American Society of Metabolic and Bariatric Surgery. And so without further ado, Dr. Davis, welcome to the show tonight. How are you doing?
Great. Thanks for having me, Baxter.
It's good to see you again. You know, I was just thinking as I was introducing you, we were in Houston for a long time, and I don't remember how long it was, but you know, we were both, you know, in the whole realm of plant-based medicine for a while, and I don't think we met in person until we were both speaking out of town at one point.
Yeah, it's funny how that is. Like when I happened upon plant-based medicine, I didn't know anybody else was doing it. Like it just seemed like I had come across something that no one was talking about. I didn't know who to turn to. I didn't know there were other doctors doing it. It was it was a weird time back then.
Yeah, we were all in our silos, and I don't think there were there weren't a lot of conferences, and there weren't the different mechanisms to connect everybody. And so, you know, it's a fascinating thing. So, but anyway, we, as I said before, you know, this whole issue of weight loss surgery is one that, you know, I get asked by patients. And, you know, the mantra used to be you have these people who are 1,000 pounds or 600 pounds or whatever the case is, you know, getting weight loss surgery. But sometimes I get individuals who come in and, you know, maybe they look a little overweight and I'm not sure, well, would you benefit from it or not, et cetera. So take us through that whole process. Let's start off from the beginning. You know, what is weight loss surgery? How does it benefit patients? Who's a candidate, et cetera? Just kind of walk us through that whole process.
Right. Yeah, it's a long story. So I hope you had a little bit of time. There's so much to talk about. I mean, like, so first of all, when you start talking about weight loss surgery, you got to kind of think to yourself, you know, what is obesity? Is it really a disease? There tends to be in our society a little bit of a blame game where we look at people that are overweight and say, oh, this is your fault. Or we think to themselves, like I did after I learned about plant-based diets. It's like, oh, I just got to, you know, put these people on a plant-based diet and they won't be obese anymore. But that's kind of simplistic thinking, right? So I started doing that, actually. I had a group of people I was doing. I also got boarded in medical weight management as well as surgical. So I started doing a medical weight management program based on plant-based diet. Now, the interesting thing is we were looking at our data because, you know, in surgery, we keep very close track of our patients and our data. And I was doing the same with our plant-based diet. And my father, did you ever get to know my father, Baxter? Did you ever meet my father?
I've never met your father. I've heard about him.
So a little bit of an old curmudgeon in the surgery world, but he was looking at the data and he said to me, he goes, "You know what I think about your plant-based diet?" And I was like, "What?" He goes, "I think you're committing malpractice."
Oh no.
But his point was this:
Oh
is
my
that I was,
goodness.
yeah. So the point, his point was this though, that I'm seeing people that are morbidly obese, and I'm telling them they need to do this diet instead of surgery.
Uh-huh.
And looking at the data between surgery and plant-based diet, there's no comparison. There just is no comparison. And I gave this talk at the Plantrition conference recently because they asked me to talk about, weight and I got up there and said, look, plant-based diets are fantastic. You look around the world, whether it's the EPIC data study or the Adventist health study or any of these things, any large population, the vegans are by far the lowest weight. There's been multiple different randomized controlled trials, and plant-based diets do a lot better. There was a recent NIH study where they put people on, it was a crossover randomized controlled trial in ward where they put people on either a plant-based, where they put them on a plant-based diet and then switched them to keto or vice versa. Plant-based diet did great. And the most weight loss ever in a diet program over 1 year was a plant-based diet. It was called the Broad Study. And it was a pretty good study, and people did pretty well. In fact, they lost 25 pounds. Now, in my population and in my patients, 25 pounds is a failure. All right. So that's what you got to keep in mind is that a surgery is so effective that 25 pounds to a 300-pound patient isn't quite cutting it. So we got to take a step back and ask yourself exactly what is obesity. Because the other thing is we've gotten to the point now where we've become a little bit too comfortable with people being overweight, such that we almost consider overweight as normal, right? I mean, 66% of the country is overweight. So we kind of consider being overweight normal. So you see a patient. Yeah, right. And so it is normal, right? And so you see a person that's obese, and the tendency sometimes is to say they're not that overweight, right? Because we think of weight loss surgery, the public thinks of it just as like the TV shows they see, like the TV show I had or the TV show Nazardin has, where they think, oh, it's all about 600,000-pound people, but that's not what obesity is, right? Obesity, we go by body mass index, and it's a body mass index. Really, class 2 obesity above 35 and class 3 above 40. And class 3 is really where you qualify for surgery, but between 35 and 40, you can qualify if you have comorbid illness. And these kind of arbitrary numbers were kind of created by the National Institute of Health. They kind of found that to be the numbers where if you lost weight successfully, you were more likely to get rid of comorbid illnesses. But here's, I think, the fundamental question you got to ask is obesity a disease, or is this just a lifestyle choice?
Oops, we lost you.
Oh, it was getting interesting.
No, that's hold on, he's gonna come out and come back in. Anyway, so the question is obesity a disease? I made some notes here, and I've got some questions coming up. The one point that Dr. Davis mentioned was, in the study with plant-based diet, they lost weight 25 pounds, and that's a failure in the surgical unit. And here he comes back. There you go.
Okay, I'm sorry about that. No
problem. So we got you. Is obesity a disease? So that's I like that question. But go ahead. I'll interject in a minute. Go ahead.
Because I see so much that like people, tend to think that this is like a choice that people make, that this is all lifestyle choices. And I look at, so for me, the surgery is just a tool, right? It is not the end all be all for weight loss. It's a tool. I still want people to do plant-based diets. I still want them to exercise. But what you got to fundamentally look at is that the vast majority of our patients have a genetic component to their disease. And you got to remember that we evolved thousands and thousands of years ago in times of feast or famine. And what people have to understand is natural selection that controls evolution doesn't care about you living older and being healthy and watching your grandchildren, right? Natural selection only cares that you survive to the point of procreation, and that's it. It doesn't care about graduations and weddings. And so, we evolved these very complex systems that are designed to make us hold on to weight. Our body doesn't care if we're fat. It cares if we don't get enough calories, but it doesn't care if we're fat.
Interesting.
And so we have this feedback mechanism where if you gain fat, the fat secretes a hormone called leptin. Leptin goes to the very most primitive central parts of the brain control hunger, the same parts of the brain that control your heart rate and your breathing. And so if you go on a fast, you go on a diet, and you start losing weight, you start dropping leptin levels. And the body will immediately respond by, okay, he's going into starvation. This must be a fast. It must be a cold winter. I'm going to make him eat. We're going to slow metabolism, et cetera, et cetera. Ghrelin level goes up. There's all these hormones that control hunger. And so it's very, very difficult for someone to lose weight. It is extremely difficult. Now, Johns Hopkins did a study on that show, The Biggest Loser.
Mm-hmm.
And it was fascinating because those people lost a lot of weight. I was really interested by that show, but they just about all of them just about put it back on. And when they went and looked at the people, their metabolism was seriously damaged by that, rapid weight loss that they got.
Yeah.
And so you got to look at my patients. It's not like they've randomly decided, oh, I'm going to just have weight loss surgery. They've been dieting since they were kids. They've been on a million different diets. They've been on diet medications. They've been to fat camps. Their mother was overweight. Their grandmother was overweight. And yes, a lot of this has to do with environment, but a lot of it has to do with genetics too. It's a combination. And they did an interesting study that I really thought was interesting. They asked people that had had gastric bypass and had lost weight. And they asked them, if I gave you a choice, either you had to go back to your original weight or you could be blind, what would you rather be? And they choose blindness. Or if you said, or you could be deaf, they choose, I'd rather be deaf. Which is interesting because if you ask a deaf person, would you rather be blind or something else? They're like, no, I'm just fine with my deafness. Or if you ask a blind person, would you rather be blind? So the study showed just how much people do not like being overweight. And when you look at a obese patient and you do a functional MRI of their brain, they lack dopamine receptors in the arcuate nucleus of the brain, which is kind of the brain that controls a lot of impulses and a lot of activity. And so it's the same area of the brain that controls alcoholism and cocaine addiction. And when you look at an obese patient's brain, it looks exactly like a cocaine addict's brain. Or an alcoholic's brain. So there's a lot more to this than just a simple choice. It's not that my patients are just choosing to be overweight. And so when we're looking at surgery, you don't just come in and say, oh, I want to have a weight loss surgery. You have to go through a whole program with us. You have to see our dietitians. You have to see our psychologists. We have a medical team. We prepare people for surgery. We make sure they have done everything they can before to lose weight and that this really is an appropriate procedure for them. But at the same time, we are keeping in mind that these people are really challenged with weight loss. It's not as easy as it seems. And then to top that all off, you add in socioeconomic factors, education levels, behavioral habits. We have a psychologist. Just about everybody's had trauma in their life. So it's a very complex issue, obesity. It's not as simple as, oh, walk more, eat less. That just doesn't, that's not going to solve it.
You mentioned something about the brain. I want to so you say you look at the MRI of the brain of obese patients. It's very similar to that of, say, heroin addicts or crack addicts or alcoholics. Is that correct?
That's correct. If you're doing a functional MRI of the brain.
Functional MRIs. Are you saying, is it, when I think of an addict and those brains, I'm thinking that those receptors are burnt out, endorphin receptors, et cetera. What are you saying on the functional MRI in addicts? And how does that compare to the obese patients? Oops, oh darn. See, whenever we get a critical point, we freeze out. So while Garth is getting his Wi-Fi back, and I apologize, we're having some Wi-Fi issues and maybe some weather issues up there. He's going to come back in. But what I want to get at is the whole issue of this functional MRI. So what Dr. Davis is talking about is that when they see the brains of obese patients, there's similar findings that you get with patients who are drug addicts. And so I want to try to get some insight to that. So as we were saying, Garth, so basically the functional MRI of an obese patient, if I understood you correctly, is similar to that of a drug addict, whether it's heroin or cocaine. Is that due to the fact that they have burnt out receptors? I mean, imagine if you're stimulating those brain receptors a great deal, you're going to desensitize endorphin level receptors and other types of receptors. What is that? What are the significance of those similarities in the functional MRI?
Right, that we don't know. Like, is this a down regulation? Basically, what you're talking about is a down regulation, or is this some kind of genetic problem? And that we don't know yet. Probably, we'd have to start doing some MRIs, before they ever got obese to understand if that was the issue. And that we don't have data to.
Gotcha.
There does seem to be this.
Is there data that looks at, their actual current diet and how it's affecting their brain? Because people talk about it all the time about sugar being just as addictive as cocaine. So I couldn't imagine that if you were on other substances, then maybe that's why their brains look that way. I don't know.
Yeah, there's some look at that. I mean, the sugar is like cocaine is not really very accurate. That's a little bit more of a wives' tale. But there is definitely a dopamine effect in the brain from eating food. And it's interesting because at one point, they're always looking for new drugs for obesity. And one drug that they came across was called rimonabant, and rimonabant was working on the, I guess they looked at people that were smoking marijuana and they got the munchies, the endocannabinoid system, and so it blocked the endocannabinoid system. And it's interesting that if you give people that drug, they lose just all initiative to eat. It's like that's the other thing to show you that this isn't just like a willpower thing or anything. You give them this drug, they no longer have these urges to overeat, to binge eat, they don't crave these things before that they did, like ice creams and things like that.
Our detox patients get the munchies also. Our patients on boot camp, our detox patients, they get the munchies within the first 7 to 10 days. They get the munchies also.
Yeah, I mean, how much of habit is, how much is habit? How much is an actual physiologic receptor, dopamine connection? That's a little.
I mean, I think that the habit gets formed, like whenever someone is binge eating or doing really destructive dietary behaviors, I'm always looking at what are they really actually hungry for? And I think a lot of the times when people, because I've seen people too who've done the surgery and then later they gain all the weight back because psychologically they weren't prepared. Oh, he's gone.
He'll come back.
Psychologically, they just weren't actually prepared to handle the weight loss.
Huh.
There's a mental component.
Yeah. And, I see a lot of the patients who come in and we try to get them started on a nutritional plan as a momentum going into this. And one thing I want to touch on when we get to the therapy part, hey, welcome back.
Sorry about that. I don't know what's going on.
That's okay. We're going to roll with the punches. So this is good. We want to keep the conversation going. And I know that you're coming back. I know you may be having some weather issues, so we're good with that. So tell us about the mental part. So you asked a question about the mental aspect of it.
Well, what I was saying was that because I've also seen people who, I've seen yo-yo dieters, I've seen all these different things, and I've also seen people who've done the weight loss surgery and then they still gain the weight back. But that's also because their psychology, like literally their emotional habits and the way that they thought of themselves didn't catch up with what happened with the weight loss. And so there's something that has to happen, I think, emotionally and psychologically for weight loss to actually last.
Yeah, we do a lot with, emotional. There's all kinds of techniques that have been looked at: cognitive behavioral therapy, emotional therapy, dealing with traumas. I like cognitive behavioral therapy the most. It's the easiest to put forth. It all helps. We look at obesity as this kind of like multifactorial disease that needs multifactorial treatment. I can't stress enough, you can't just tell someone to eat differently. That's just not going to work. They need behavioral change to eat differently. They need to know what to eat. The other thing in the bariatric world, it's slowly changing, but they haven't caught on to this this plant-based eating, and they're still telling people to eat protein, 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 and these patients are stuffing.
Yeah, I know the protein. What I'm going to do when you come back, Garth, I'm going to, real quick, I'm going to share my screen. Dr. Davis is the author of a well-known book, Proteinaholic, and he was talking about this whole concept of eating protein, and we get that a lot. Proteinaholic is an excellent book. I invite you guys to take a look at that. But let me bring you back. So, God, help me out in terms of, I want to go into my clinic, and I see a lot of patients. And so I've got somebody coming in, they've got a BMI of 45 or somewhere thereabouts. Who is the ideal patient to refer to? Help us out in terms of patient selection and walk us through that process.
So when I'm looking at a patient, I'm looking at a few things. How long have they been overweight? Is this someone who all of a sudden got overweight 2 years ago because they went on, went on Paxil, which is a really strong weight indicator? Because someone like that, I'm not as interested in doing weight loss surgery in.
Okay.
I'm looking for people that have been overweight for many years, tried many different diets.
Greater than 5 years, or?
Well, some of the insurance companies require 5 years. Yeah, I would say 5 years is a pretty good matter. I mean, here's the thing is, even if someone's only been overweight 3 years or 2 years, the surgery is going to be beneficial for them if they now have diabetes or hypertension or sleep apnea. But the ideal patient to me is someone who's been overweight for many years, has a family history, has a BMI above 40, or has a BMI between 35 and 40, and has a clear comorbid illness such as diabetes. The one thing these weight loss surgeries are somewhat phenomenal with is the diabetes. I mean, that's the one area. And I can't tell you like how many times, sometimes did you ever watch Star Trek when you were younger?
Very, very little. I may have seen a few partial episodes.
I was a Trekkie. So there was an episode where the doc, beam me up, Scotty. So there was one time where the doc was they had gone down to Earth, and it was the 1980s, and one of them gets appendicitis or has some kind of neurological problem, and they're going to operate on him, and the doctor talks to the guy's like, "You're going to cut him open? Are you guys barbarians?" And so sometimes I think to myself, God, this is barbaric what we do. And I want to hang up the scalpel. I really do. I want to say this is how you cure disease. But then I see someone who's BMI, 37, and they got the worst diabetes in the world. And while I want to cure their diabetes with diet and exercise, and I want them to eat like me, and I want them to exercise like me, and I push them. It's amazing to me how within a few days of this weight loss surgery, their diabetes is gone, just completely gone, never to be seen again. And it's just, it's somewhat miraculous. It doesn't mean, look, we're not born with a deficit of surgery, right? I mean, the thing you got to look at with obesity is that it's like an end stage disease now. Had we caught it early on, had we done this cognitive behavioral therapy when they were kids, had we changed the eating habits, had we fixed farm bills so that fruits and vegetables were cheap and cheeseburgers were expensive, we wouldn't be in the situation we are. So we are, plugging holes in a dam. But we are kind of plugging them somewhat effectively with the surgery.
So basically, the patient greater than 5 years or a long time, and then 3 to 5 years with a comorbidity can sometimes be beneficial. Now, typically, I'm screening these patients for risk factors. Obviously, make sure there are no acute cardiac issues. I recall one patient of mine I saw after surgery. They took her without a cardiac screening. She arrested on the table, and then they resuscitated. And then they asked me to see her afterwards. But I said, "Okay, not clear for surgery."
Right, not clear for surgery. Right, you say that on the table. Yeah.
But anyway, but clearly, we screen these patients. But in my practice, I like to take an integrative approach because I understand the point you're making. We have patients who, of course, have, multivessel coronary disease, and some of them may need surgery. We have also patients with cancer that we're treating with nutritional support. And some of them benefit from both the chemo and the nutrition. And I was just talking to my PA the other day, And we have a philosophy in treating most of our patients with advanced disease, but let's say take the cancer patients, we nourish the bodies to optimize the bodies to tolerate the chemotherapy. Because the chemotherapy is sort of like letting a gas mask off in a room of people. You got the good guys and the bad guys. And the guys you want to preserve, you want to give them a gas mask. And the guys you want to pass out, you leave them without protection. And so if you nourish the body, if someone's going to get chemo, maybe radiation, you optimize the body to undergo that trauma of chemotherapy. And I think if you get somebody who's morbidly obese, and the patient we've seen, we'll put them like a juice feast before they go to surgery to get them rapidly detox. I understand you guys like to have that liver shrunk as well.
Exactly.
To an extent. And we found it to be helpful. And when they get into that surgery, then they get they already have some momentum. They're feeling better. Then they tolerate surgery better. And then that gives them that momentum coming out of surgery. What are your thoughts in terms of an integrative approach where, a plant-based diet is one thing, but we use raw, we use detox, and we find that to be more effective than just plant-based, even in disease like heart failure, diabetes, and the like. What are your thoughts in terms of using an aggressive, intensive nutritional program in the setting of weight loss surgery as an integrative approach for these patients?
I love it. We do, we have a pretty integrative approach. I've got a pretty big team like you do. I've got dietitians and psychologists and behavioral therapists and an exercise therapist. All my patients go through all of that pre-op. I don't do as intensive as your boot camp is. And it'd be interesting to see how well that, how your patients would do going through surgery and how many you could keep off of surgery. But of course, if you keep them away from surgery, one thing I would call, anybody could lose weight. I mean, losing weight isn't the key, right? I mean, I could put someone on chemo and they lose weight, the key is, how do you get someone to lose weight and lose weight safely and keep it off for a long period of time? So, with weight loss surgery, we don't count our chickens until they hatch 5 years down the line. So we want to know what their weight is 5 years from now. That's how we do most of our studies. What's the 5-year weight? We've got 30-year data, but the 5-year weight's a real key number for us.
I guess when you come back, one thing I'd like to know, what is your 5-year data? It's also on the behavioral side. What are some of your thoughts in terms of people, let's say you got someone who's morbidly obese and they're in the clinic and, they're contemplating undergoing gastric bypass surgery. What would be your recommendation? I mean, how would you evaluate that patient from the standpoint? What are some of the emotional things I need to look out for in terms of bringing that patient to surgical treatment? Hey, Garth, I was asking Asosa to give us some insight. She does behavioral therapy with her patients and counseling. And I was getting her input on that patient coming in with, 600 pounds, et cetera. What are some things I need to look out for on a behavioral standpoint, along the lines of integrative approaches?
Well, I don't prepare people for weight loss surgery. I'm dealing with actually not, I'm not in that setting anymore.
Gotcha.
But I deal with people, like one of my clients right now is 400 pounds.
Uh-huh.
But when I'm looking at behaviors, again, I'm going deeper. I'm looking at what is their relationship to food, whether or not they're actually even eating. People have this misconception that people who are obese eat a lot, and actually most of them don't even eat enough to get their metabolism to work efficiently.
Wow.
And so really I have to force them to eat. They just do this random skipping of meals, not even real like fasting. Like a lot of people who are overweight and obese are just doing this willy-nilly sort of like, I have a muffin and then I have a Snickers bar and then, oh, I forgot to eat. Okay, let me go get some soup. They're not eating in a way that their metabolism can actually fire in a positive way. So I'm usually trying to get them to eat a lot more and consistently and use fasting targetedly, instead of just like this haphazard, I forgot to eat. But when we look at emotions, it's different for different people. So I have a guy right now who's 400 pounds and his a lot of his stuff is tied in with his mother. Like you'll find that a lot of people have stuff that's tied into family stuff or when they were younger, how they were treated, what people said to them. I have one client who's overweight right now, who's releasing the weight, and she had to go through the process of kind of just like talking through all of the, because her mother used to call her things like Miss Piggy. Like when if you were being antagonized by your parents, you're really young. Or I've had a client who got into this yo-yo dieting, but her mother put her on a diet when she was 12 years old. And that like stuck to the point where she just couldn't know how to be on anything but a diet. And so she goes through all these diets, and then she finally gets to me and I'm like, we're not dieting anymore. Like, this is not a diet.
Wow. That's an interesting point you make in terms of the fact they're not eating. Like, God, what is your data showing the patient you're seeing? I don't know if y'all do nutritional assessments. Are you finding that most of your patients eating a small amount or not eating enough, or what? That's something I've seen.
You mean preoperatively?
Yeah, preoperative. The guy that Jared who lost weight. I mean, he used to eat like 2 pizzas and a couple of buckets of fried chicken, and that's what. I mean, are you seeing a lot of people who are like serial dieters and who are just kind of eating so?
Oh, everybody's a serial dieter. But there's a lot of things. First of all, everybody says they don't eat a lot. Because we kind of just, we think what we think is a lot now is, is a ton. What we think is a normal meal is actually too much. The human body doesn't need that much food. In fact, part of like when we do these weight loss surgeries, we're making the stomach smaller because we have these big, huge, gigantic stomachs, not so that we could get our money's worth at a buffet, right? It's there because we used to eat in times of feast or famine, right? There was a kill or there was a harvest or a gathering, and you would eat as much as you could because you were going to hibernate. But that's not how it is anymore. So I get so many patients that come up to me and they're like, well, I want to get weight loss surgery, but I don't eat that much. I know that's not true because if I do weight loss surgery, they lose weight. So obviously they're eating more than they're burning, regardless of whether they think they are or not. The other thing is, they definitely, you're completely correct in that they're eating, here and there. There's a lot of grazing. There's not real meal times or concentration. There's no real concentration on fast. People think that they have to constantly feed their body all the time. And, there's also this, when people do diet, they do make this huge mistake of thinking, oh, I'm not going to eat. Like, I can't stand when someone says, I did a vegan diet, but I was too hungry. Man, if you were too hungry, you just weren't eating enough. I mean, with a vegan diet, it's low calorie density. I, stuff my face on salads and potatoes and beans and all that kind of stuff and don't ever gain weight. And my patients that follow what I say don't gain weight because that stuff's not going to make you gain weight. So there is this idea like, oh, I'm going to go on a vegan diet to lose weight, and they just eat salads. Because the other thing, and this is a huge problem with obesity in America, is we keep doing the same thing over and over again, expecting different results. And that is we keep doing low carb diets. We fear the carb in America. So whenever I sit down with my patients, I always ask them, I say, look, Europe's catching up with us. So they followed 500,000 people for 12 years. What do you think the number one food was that was causing weight gain? And what do you think they say? Bread or carbs or sweets? And the answer is no. The answer was actually chicken. Chicken was the most associated with weight gain. So then they freak out, right? Because they're like, whoa, every doctor's told me chicken is my diet tool. And well, look, we eat more chickens in this country than any other country in the world. How's it working for us?
Is it working with it? You mentioned carbs and Dr. McDougall Zorro made a comment that McDougall says is not how much you're eating, but what they're eating the wrong foods. And I think your point alludes to that.
I agree with Dr. McDougall on this.
And so the what actually, and I tell people that, in fact, when we put them on our detox regimen, our boot camp, it's actually pretty strict, I like to say precise. And we actually don't restrict the portions or calories. We say we more focus on the what and then the how much. And that approach has worked. In fact, not only did it work in our study when we published the work, when we put people on our meal plan, we gave them more food than they could eat. And if we said if you didn't get enough, come back for more. They ate from our restaurants. So we knew we controlled the what. And we found that their caloric intake went down significantly. And it was natural. And in fact, they could not finish the food that we gave them. So, I mean, the point you're making, has been borne out in our research and other people's too. So the what is a big point. I mean, is a key factor. And
it's a huge factor.
It's huge because you can be obese and be starving. Literally, right. You're not getting any nutrients. So you had a burger, a pizza, none of that had any sort of like, it didn't give you any of the things you need to produce ATP or whatever. And so you're, you know what I mean? You're starving.
Yeah, no. And they've done several really interesting studies with this. So remember, I mentioned the most weight loss ever in a year diet plan was the Broad study. And in the Broad study, it was not calorie restricted at all. They told the patients, eat as much as you want, fill yourself up, but you could only fill yourself up on these foods, which were all plant-based foods. And that was the most successful diet that's ever been done on record with a year diet follow-up. And then the most recent NIH study, which is just fascinating, the concept with ketosis, everybody thinks that if you're in ketosis, you're likely to eat less. So the NIH studied this. They put, I don't know who volunteers for these studies, but they put 40 people in an NIH hospital, and they fed them a ketosis diet, and then they fed them a vegan diet or vice versa. And what they found is, first of all, the vegans ate less calories altogether than the ketosis diet. The ketosis diet lost a similar amount of weight, but most of it was water or muscle. They didn't lose any fat whatsoever, but in the plant-based diet, they were losing fat.
Wow. So that's I'm glad you pointed that out, because people are concerned about losing muscle in the plant-based diet, but that's not what the studies show. You're losing muscle with the keto diet.
Right.
Because that's one of our questions, what do you think about the keto diet? So basically, they lose a lot of water, and it seems not to last very long. And at least the patients I've seen come in who've done the keto diet, they can't tolerate that diet for very long.
No,
it's not sustainable.
It's not sustainable.
Yeah.
Because our body is very keenly tuned into our carbohydrate stores as far as glycogen. Like your body, when you start dropping glycogen, that's when you get, hangry. Hungry and angry. And for an athlete, that's when you're what we call it the bonk, or when you're running and you just feel like you're about to die. Our bodies are very tuned into our carbohydrate stores. And so going to ketosis, you're really messing with that. The other thing is you're eating pro-inflammatory foods. In that ketosis study by the NIH, they actually became insulin resistant. So none of them were diabetics before they came in. They became insulin resistant on the ketosis diet, because insulin resistance, diabetes, is not caused by carbs. It's caused by fat.
Yep. Yeah.
It's fat gets into my cells. Yeah. And so, people don't understand that. Even endocrinologists don't understand that. If you ask an endocrinologist what causes diabetes, they don't really look into what causes it that much, but they'll typically tell you it's the carbohydrate intake. No, it is absolutely not the carbohydrate intake.
Yeah.
In fact, the people with the least diabetes eat the most carbs.
Yep. It's really a metabolic disease. And as you point out, intracellular fat contributes to that. It's probably intracellular inflammatory mechanisms that's working against the insulin receptor. So,
exactly.
People don't look at the mechanism. And I tell my patients that all the time: diabetes is not a blood sugar disease; it's a metabolic disease. And so, and we have similar results as you do when they go on a plant-based diet. Many of our patients are able to come off insulin within a day or two, almost immediately. They're able to eat fruits and other things that they weren't able to tolerate when we were consuming animal protein foods. And so it's kind of an amazing situation. Take us in the operating room, Garth. So there, you've got patients. And so, how do you, my understanding is that there are multiple different surgical approaches. There's the sleeves, there's the actual gastric bypass, et cetera. Walk us through that process, and how do you make that decision as to what approach you take, and kind of give us a brief description on those different surgical approaches.
Right. So one surgery that was popular in the early 2000s. So you go way back. The first real surgery for weight loss was called the GI bypass. And that was basically they bypassed most of the intestine. People didn't absorb food. They lost weight because if you don't absorb the food, you lose weight. But they also got deathly ill because they didn't absorb their food. The next idea was this thing called a vertical banded gastroplasty, where when people say they had their stomach stapled, they would staple the stomach and put a little band around it, and that didn't work very well. People regained their weight and vomited a lot. It was kind of like a forced bulimia.
Oh boy.
Then there came a surgery called the lap band. That was really popular in the 2000s, but that didn't end up working very well. The band would erode or slip. And if you think about it, it's not, remember I told you, the point in surgery is to control hunger mechanisms and these kind of physiologic things that we've evolved over time that make it really hard to make diet changes. I mean, obviously, if everybody was trapped in your office and they only ate what you told them to eat, and they never did anything different, there would be no surgery. They would be successful. The problem is there's a few select people of the patients we see that are able to do that. The more we could, if I could get more people to do it, and I've got some ideas on how to do that, maybe I can hang up the scalpel one day. But the fact of the matter is, that's kind of difficult. And so what we're trying to do is do surgeries that control these hunger hormones. And the band didn't control any hunger hormones. It just restricted how much they could eat. And we would tighten that band, right? So we could tighten it by adding more fluid to it. So you eat less, but then you're eating less. So what happens? Well, what we talked about earlier, your leptin level drops. Your brain says, oh my God, I'm going into starvation. It makes you even hungrier. And you're not able to eat the food that we want people to eat. They're not eating broccoli if their band's that tight. So the only thing they can eat is a milkshake or ice cream, and boom, the band was not successful. So then came, all along, the kind of oldest weight loss surgery has been the gastric bypass. That's been around for a long time. What we do is kind of cut the stomach at the very top and make it into a small stomach, basically the size of a thumb, a little bit bigger. And then we bring a piece of intestine and join it to that. So the food goes down into this little stomach and then down the intestine. And then we reconnect it to the intestine that comes from the pancreas and the liver so that we get the digestive juices, and then they mix together. And this has several effects. By bypassing the larger part of the stomach, there's a hormone called ghrelin that controls hunger, and that ghrelin level drops tremendously. And also, by sending food down the intestine fairly quickly, you stimulate these incretin cells, and they secrete a hormone called GLP-1. And this is the exact same effect you see from all these diabetes medications. In fact, the diabetes medications were designed off of the bariatric effect, which is this rise in GLP-1. So Byetta, Ozempic, all these different medications work the same kind of pathway, and that's kind of the effectiveness with diabetes. So the gastric bypass is the ideal surgery for diabetics. It works extremely well for diabetics. It works very well for people that are super overweight. We're talking like the 500 pounders. They're going to do better with this surgery than the other surgery I'm going to mention.
But real quick, just make sure I understand, on this gastric bypass surgery, you're essentially reducing the size of the stomach so the transit through the stomach is faster. Is that correct?
The transit through the stomach's faster, but there's hardly any stomach.
Yep.
And we're also, the other thing the bypass is extremely good for is people with severe reflux disease, because there's now no stomach to reflux bile and acid.
Okay.
So the ideal gastric bypass patient is someone who has reflux or is severely diabetic, not like a little bit diabetic, but severely diabetic, or someone who has a lot of weight to lose.
And what is this doing to their capacity to digest food properly and to absorb their nutrients?
Yeah, the bypass is not a malabsorptive procedure. So they can absorb the nutrients almost fine, almost. So there are a couple nutrients that are absorbed in the proximal duodenum that are bypassed that we have to watch out for. So we have to watch out for B12 deficiency.
B12. Yeah.
We got to watch out. And not everybody gets these, but you have to watch out for it. The other thing could be a vitamin D deficiency, although I don't really think that is from the surgery. I just think everybody's vitamin D deficient, because we started measuring our pre-op patients and they were pre-op, their vitamin D was deficient. There can be an iron deficiency from the surgery because iron is absorbed in the proximal duodenum. So we're very, sometimes zinc, we look at every few months we check our patients. So we're basically checking their iron levels, their calcium levels, their functional calcium. So we look at parathyroid hormone, which is kind of checking how the body's managing with calcium, and B12. but they're not malabsorbing nutrients like the first surgery that was ever done.
Gotcha. So basically, you would supplement these patients as needed based on their lab findings and the like.
Based on
Gotcha.
their labs, right?
Okay,
And then the most recent surgery was a surgery called the sleeve gastrectomy. So that's a very common surgery now. All we are doing is cutting out the excess part of the stomach here. So the food still goes through to the intestine in the normal manner. So there's no bypassing any intestine. We're just taking out the larger part of the stomach. That part of the stomach secretes a hormone called ghrelin, which makes you hungry. So there is an anti-hunger effect as well as a earlier satiety. In fact, if you look at that stomach under a microscope, it actually has elastic fibers in it.
Mm-hmm.
And so it's made to stretch. And so, again, it's made to stretch because thousands of years ago, you better eat a lot when food was around. But of course, now, it could be a winter's night at 2 a.m. and you could get a burger. So we take that part of the stomach out to limit that stretch. A pretty effective surgery. Not as effective for weight loss as the gastric bypass. So the more someone weighs, the more I lean towards a bypass. Not as effective against diabetes because the food is still going past the pancreas. It's not having that GLP-1 effect that the bypass has. But it can, a low-grade diabetes is basically a weight issue. So if you lose weight, you're going to cure the diabetes that way. So if someone's just like on one drug and their A1C's, 6.8, sleeve's a great surgery. Someone's got, an A1C of 11 and they're on a ton of different insulins, then I'm more likely to suggest a bypass. And then the last surgery is called a duodenal switch, which is a very complex surgery. It looks a lot like the very original surgeries that were done, where it is a malabsorption procedure where we bypass a lot of intestine. And it works by basically making a patient not absorb. And they get lots of vitamin deficiencies.
Yikes.
So they don't absorb fat very well, so they lose all their fat soluble vitamins, and they lose every vitamin, zinc, copper. I mean, you got to heavily supplement these patients, heavily supplement. I did it for a while because it is the best weight loss surgery without a doubt. But again, I don't, and we shouldn't judge success just based on a number on a scale. It should be,
exactly,
how healthy are these patients afterwards? And I just found that patients with the duodenal switch they were very happy with their numbers, but they just looked very sickly to me.
So is this done for who would be the ideal patient for this? I mean, who would?
Oh, that's the morbidly obese. So we're talking BMI above 60, above 65. So I did it on the most overweight patients. In Houston, I was really referred some of the largest people that you've ever seen, and so a bypass did well with them. Like I had a guy who weighed 1,000 pounds, and I did a gastric bypass on him, and I think now he weighs 500 pounds. Good success, right? But he still weighs 500 pounds. With the duodenal switch, we got them even lower with that, but there's just too many complications with it.
Can these procedures be reversed to some extent? Let's say you do a duodenal switch and the person does horrible. Can you reverse
that? Yes.
Okay, so all three of these, because it seems like the gastric bypass, the sleeve, duodenal switch, they can be reversed if you have problems.
Well, you can't reverse a sleeve because we're taking that stomach out of the body.
Oh, gotcha.
So you can't really reverse a sleeve. There are some sleeve patients that develop severe reflux because if you think about it, we're tightening the stomach. It's like putting your finger over a garden hose. So it increases the pressure, so acid could reflux up into the esophagus. And if that happens, then they get a gastric bypass.
So you can modify the sleeve with a bypass and to repeat that. And the duodenal switch can be reversed. So these things are good to know. Yeah. And so who are the patients who fail? I mean, so you do all this hard work and, they lose weight initially. Who are the people that come back with weight gain? Who are your failures and what's the profile of the patient that fails?
Right. Well, I mean, you could probably guess, but there's a few factors. Okay. First of all, you've heard the saying, if you do what you always done, you get what you always got.
Yep.
Eventually the body does adapt and it will allow you to eat more. The other thing is the metabolism drops dramatically with weight loss surgery. Same thing as what happened in the Hopkins trial where they were looking at the Biggest Loser contestants. their metabolism dropped dramatically. Their hunger is going to increase. So at least we could, stem the hunger with the bypass and the sleeve, but their metabolism has dropped. So they may have burned 2,000 calories just sitting around at home. Now they're burning, 1,200 calories or less. And so in order to lose weight, they need to eat super low amounts, but now their body's adapted to the surgery so they can eat more. And so you get to this area where you're just not going to do as well. And then they go back to, bad eating habits like we talked about before. Grazing. So grazing is a really bad problem because now you're eating all during the day. So you can't eat a lot at one time, but you're eating a little here, eating a little there. And you're going to get the weight going back on. They're eating the same junk food that they were eating before. With the bypass, you can't really eat sugary foods because you get something called dumping syndrome.
Yep.
But you can, you can eat fatty foods and fried foods and the kind of foods that are making America fat to begin with. So if you don't change behavior, and I go this over and over, I go over this with my patients, that this is a lifestyle change. The surgery is a tool to help you make that lifestyle change, but I still want them to go on a predominantly plant-based diet. I don't push the terms vegan or vegetarian, but predominantly plant-based diet. And I want them to get 8 to 10,000 steps a day. I don't call it intermittent fasting. It's really more time restricted eating. So I have them eat at the exact same time every day, never between those times. And there's a 14-hour fast every night. So there's multiple different things that we do to try to assure that that's going to be successful. And typically, of course, the people that aren't successful aren't doing that. Now, there are some factors that make it hard for them. Most of my patients have severe osteoarthritis. For me to tell them to go and walk 10,000 steps, it just ain't going to happen. There's socioeconomic issues too. It's amazing to me now, especially you get it in Houston too, but I'm in the Appalachian Mountains here, and I talk to someone, I tell them, well, I want you eating quinoa and amaranth, and they're like, what in the hell are you talking about? And so it's just, there are socioeconomic cultural issues, and I tell them I want them to eat stuff that costs more. Well, Doc, I could get a burger. I could feed the whole Kentucky Fried Chicken's got $10 for my 5 members of my family. Why wouldn't I do that? So you have to get those issues are always going to play a part.
Yeah, no, I hear you. I hear you loud and clear. So metabolism, one little side on this, increased muscle mass, typically increased metabolism. Do you ever have trainers who have them do exercise to increase muscle mass to help with the metabolism?
We do. We actually have an in-house trainer. It's funny. And so it's very hard in any kind of weight loss situation. It's very difficult to gain muscle mass. When you're in an acute weight loss situation, you're going to lose muscle mass. Your body will try to go through gluconeogenesis, so it's going to burn through muscle if you're not giving it the calories it wants. And so we see a lot of muscle loss with our patients when we look at DEXA scans and things like that. And so eventually you start to try to rebuild that muscle, but it's somewhat difficult. I mean, the key to building muscle is to having excess calories. It's very hard to lose weight and gain muscle. This is the bodybuilder's dilemma that they try very hard to work through, but it is very difficult to get in that, especially for a patient who is so restricted. And I mean, my patients are just not the average bodybuilding. I'm going to go and build a bunch of muscle. They'll build some muscle, but not enough where they're going to totally reverse their drop in metabolism.
No, I understand. I want to show you, flash your book up to the audience real quick. Everyone, Dr. Davis is the author of Proteinaholic, and it's an excellent book, How Our Obsession with Meat is Killing Us. Excuse me, sorry. And, it's an excellent book in terms of just sort of going through the literature. And we think protein, and people, when they say protein, they're talking about animal flesh, animal protein, where you get lots of protein from plant food. So, but the word protein is typically synonymous to animal protein. But and I know you touched on this, but in our final minutes, to just kind of again drive home the message: plant-based diet in the setting of weight loss surgery. I mean, I get a lot of patients come in and say, "Well, my surgeon says I've got to eat a lot of meat," and so on and so forth. I mean, what's my response? I thought my buddy Garth says what?
Yeah, that's your response. Yeah. Next thing I know, I got a lawsuit on my desk. But yeah, it's kind of crazy. This, well, look, I mean, as much as I've been an advocate for weight loss surgery, I'm more an advocate for plant-based diet. So I don't want people out there to think, oh, I just need to get surgery. Look, if you could lose the weight, like Josh Lajani.
Yes, he runs with PCRM, the exam room.
No. He's been on that, but he doesn't run it. That's a different guy. But Josh he used to be morbidly obese. And he goes to a lot of the plant-based diet things, and he talked to me a long time ago. What do you recommend? Look, weight loss surgery is an option. It's unlikely you're going to be able to do a plant-based diet, but you could do plant-based diet and running and stuff like that. Josh, I saw him in Marshall, Texas. I had seen pictures of him before. I saw him at Marshall, Texas at a talk. The guy's skinny as anything and beats me in a race. So he turned it all around with plant-based diet and exercise. You can turn it all around with plant-based diet and exercise. So that's the first thing I think people really need to know is that it's an answer even if you don't want surgery. But if you're really struggling and you need surgery as a tool, that's fine. You need it as a tool. Afterwards, a plant-based diet is like the best thing you could possibly do. So we talk about the people that are regaining the weight. A lot of them are they're drinking protein shakes. They're stuffing their mouths with, they love to take cheese because their doctors tell them to do this, Baxter. They tell them to take cheese and wrap turkey meat around it. And so the thing is, I would go to these we have a thing called Obesity Week. It's a week of like all the scientific presentations on obesity. And I sit in that week. We're talking about obesity, right? For a week. We hardly ever talk about food. It just, no one talks about food. Wow. How are we not talking about food at an obesity conference?
What are you talking about?
Surgery and medications. And if we talk about food, we're talking about macronutrients. But the funny thing is, there's no science to suggest that protein is the way for these patients to lose weight. It's really somewhat made up. And I get some of the idea I understand is that in a rapid weight loss, and there might be one point in time where you actually need a higher protein level, and that is during the point of the most rapid weight loss. So the first 6 months when you're really dropping weight very rapidly, more protein. There have been some studies. Now, these studies are done in trained athletes, not in bariatric patients, but there have been some studies that showing a higher protein level will preserve muscle mass a little bit better. But once you get to a baseline and you're not rapidly losing anymore, you got to stop and think to yourself, the RDA for the average woman is 45 grams of protein a day. Mm-hmm. Now, remember, that RDA is based on 2 standard deviations above the mean. So the average woman actually needs a lot less, but they wanted to make sure that everybody got it. So they say 45 grams of protein.
That's a lot.
Doctors, that's a lot. And our doctors, bariatric surgeons are telling their patients to eat 100 grams of protein a day. So they're so busy eating protein, they're not eating any of the fiber and the stuff that we talk about that actually leads to the weight loss. And so they're perpetually hungry. They continue to lose muscle mass because they get into ketosis. And they're not healthy. They don't look healthy. If you look at my bariatric surgery patients versus another person's bariatric surgery patients, you could tell they come into me because I'm kind of a tertiary referral for people that have failed bariatric surgery, and they come to see me, and they just don't look that healthy. And I'm like, I could tell you what the problem is right now. You don't need another surgery. You're constipated. They're all constipated.
Oh my
Your
goodness.
vitamin levels are terrible. You feel crappy. And you're trying to focus on protein. As soon as they switch to focusing on fiber, fruits, and vegetables, everything gets better.
We need to do a study. I mean, we need to do a study where we get a group of people, and I don't know, maybe you can give me some names, some of your colleagues in Houston, and I've often wanted to do this where we get a group of people. And I like to put them on a detox for 2 weeks going into surgery. Have the surgery, do a detox going out a month or 2 after, and then put them on a regular plant-based diet. One thing we found with the detox is that there's a psychological change that goes in there. One thing I like about raw is that people's taste buds change.
You're right.
And so it's a more rapid change. And I think that plus the surgery and the success may give them the momentum they need, and compare that to the standard, dietary recommendations. And I think we would probably find something that's very effective that potentially could change the standard. I mean, I have the same thought process in my patients undergoing bypass surgery or stents. You need the surgery, you need the procedure because of your acute coronary syndrome, et cetera. But you also need this other intervention as an adjunct, an integrative therapy, so that you come out on the other end and you're going to do better overall. And
Yeah, I agree 1000%. And I wanted to do that study, and we were trying to get an NIH grant, but since
yeah,
COVID hit, you can't get money for anything.
yeah,
It's just shut down. And the thing is, what I really wanted to do, what I really needed the money for, is
mhm.
in order for this to work, because there's too many studies where you put people on a diet, but you got to, it really, you want to carry it out a long term, and they just can't do it long term unless you provide them the meals. So I wanted to provide them the meals, so that I could do that study. And I wanted to provide them the meals to compare it to a ketosis diet and a high protein diet. But I need
Yeah.
money.
No, I agree. The money is an issue. We come. It's also any thoughts, questions. This is quite an amazing discussion here. I mean, I learned a lot about gastric bypass, and certainly my patients are morbidly obese. I think I'll be able to do a better job of selecting people who would benefit from this, and like you say, as a tool.
Right.
Also you counsel a lot of patients or a number of patients in this condition. What are your thoughts or any, lasting thoughts or questions?
No, not really. I'd like to hear about your triathlons, or what are the things that you're doing?
That's right. This guy's a super athlete.
Oh, I don't know about Uber athlete. 50-year-old guy trying to stay young, not let age get him. No, I mean, I've done an Ironman. I've done quite a few marathons. Now I'm doing calisthenics, and I go to CrossFit. I think it's important to kind of really switch up the exercise quite a bit. I've done kind of gotten into the anti-aging fields, and like, what is it to
That's what I'm
age?
all about.
Yeah. Oh, it's good. That's a good thing to be about. I think because the thing is, the anti-aging research, I think, will have, like, the more we study that, will have an effect on these chronic diseases. It's not just about
Oh, for
getting
sure.
old. It's also about preventing these chronic diseases. And so now, like, I love Ironman. It's a lot of fun. I'm not sure it's that good for you.
Isn't it? But it's still cool. I think it's great mentally.
It is, like, mentally. Look, doing that was like, after I did that, I was like, "Oh, there's
I could
nothing
do
I can't
anything.
do." And I
Yeah.
had a patient, I had a great gastric bypass patient, who, he saw me do that. Then he wanted to do triathlons. The guy's 500 pounds. And so I did a gastric bypass on him. And he goes, "I promise you, I'm going to do." He had a band before, so we actually revised his band to a bypass. You think to yourself, he's had one weight loss surgery that didn't work. He's been overweight his entire life. This isn't going to work. And the guy was huge. He said, "I promise you, I'm going to be ready to do a triathlon, and I want you to do one with me." And so him and I did a triathlon in Miami together. And that was
Wow.
really crossing the finish line with him that was something else that really was enjoyable.
Whoa.
Yeah,
Wow.
because that guy really so
Whoa.
when I was training for Ironman, there were many times I thought this is just impossible, and so I kind of had this motto that impossible is a dare.
Yeah.
And so he took that, and he went with that. Impossible is a dare, and that's been like his whole life has been impossible is a dare. And I love seeing him kind of take on that kind of mindset because, as you know, I'm sure in your practice of counseling people with behavioral, mindset's everything, right? If you're in a
Mine was
mindset,
everything. Have you heard of David Goggins?
oh God, yeah. I mean, he's a little crazy though.
He's a little crazy, but I love him.
Yeah, I mean, I love him too. Like, what's not to
He's
love
like
about
my
that?
trainer in my head.
Yeah, he's amazing. But like Goggins is a little scary to me. Like, he's a little bit like, I feel like if I was like he was training me, I'd actually like over. So now I'm getting into biometrics and quantifiable self. You know what quantifiable self is, like getting all these metrics and stuff. So I constantly wear this thing called Whoop. Have you ever heard of Whoop?
No.
It's constantly measuring your heart rate variability, and it could tell if you're well rested or how
Okay.
well you slept. And so
Okay.
it tells me, like, before I got on this, I had a really hard workout because my Whoop said you're ready to train hard today, so train hard. But tomorrow it'll probably tell me, you're not as well rested, train easier today.
Oh,
So
wow.
Does it measure your REM sleep and stuff like the
it
Aura
does.
ring? Oh, okay,
It's
cool.
exactly like the Aura ring. It
I'm
does
gonna
the
get
same
the.
stuff.
Yeah, I just ordered
Yeah.
an Aura ring.
Yeah, it does the same stuff the Aura does.
Okay.
It gets a little bit more data to it, but yeah, it's the same
Okay.
stuff. So it's basically telling you You're working out too hard, you're working on, and I'm working on something now. Okay, you will like this, but I'm working on this idea. When I talk to my patients, and I really try to get like, when are you, what to eat? When are you breaking it and why are you breaking it? It always seems to come down to stress. So you probably counsel them on cognitive behavioral therapy, I imagine. You do CBT?
No.
Oh no? You don't like CBT? We should
I
talk
use,
off.
yeah, I could tell you some of the therapies that I use. I use rapid transformational therapy and emotional freedom technique, a lot of different behavioral and emotional techniques.
So I've been playing with these ideas and these different techniques, and how can I? So we know that patients that see us more frequently tend to do better. So if I see a patient every week, they're going to do better than if I see them every 2 weeks, and if I see them every 3 weeks. How could I be on their shoulder at all times? And I've been working on an app development where I'm on their shoulder at all times. And part of it would work on this heart rate variability, because using things like Cora and Whoop, and this app I'm trying to develop, I will be able to see, okay, you had a bad sleep last night. I could tell you're under stress and you're more likely to eat poorly right now. So let me now remind you of emotional cues that you've had and some of I like using cognitive behavioral interventions, if then models. Like, if I'm under stress, then I will do this instead of that, but have the app cue it based on their wearables. So I'm working on that. That's a lot of work.
Well, Doris, some of that information on Whoop. And before we close out, there's a patient of yours. I don't know if you remember the name, Elena Rose Barnett. That's my surgeon.
Elena, how you doing? Is she on? She's on right now?
Yeah, she's on now. She just sent these messages. So she had an ejection fraction of 20 to 25%. You took a chance on her. And she lost 140 pounds since 2018. Her EF is now 42%. So there you have it. So
I love it. Thanks for sharing. Yeah, funny enough, we're getting a lot of cardiology consults lately, especially with people with really bad ejection fraction, and they're calling the surgeon the sleeve of life. If we do a sleeve, it gives them life, because then they could get transplants. So
yeah,
thank you for sharing that, Elena.
Yeah. Well, anyway, guys, thank you very much, Garth. This has been a treasure of information, and I took a lot of notes. Our people have taken notes. Our audience is given a lot of good information. I want to get that information on Whoop, so please email me that heart rate variability. But let me close out, and I'll see you guys back on stage. Everybody, thanks again. This is another evening, and time flew by. But, the whole issue of weight loss surgery can be effective for people with morbid obesity, but it has to be in the context of lifestyle modification. So, there is a place for this, but you have to be in the mindset of doing the work in addition to having the surgery. And I want to thank Dr. Garth Davis again for his wonderful insight on this very complex topic. But we will see you next Monday. We'll be talking about colon cancer. Many of you may have heard of the actor Chadwick Boseman, who died of colon cancer at the age of 43. And so we'll have Dr. Ed McDonald on next Monday. So please tune in. This is a very, very important topic, and he'll be enlightening us about colon cancer and natural ways of preventing it. Cancers begin early in our lives, long before the diagnosis is made. And so you need to understand how to treat your cancer before the diagnosis. So anyway, again, thank you for joining us this evening. And as always, keep it